Thanks so much, everyone, for joining this Wonka Europe talk. I guarantee it's going to be really interesting and inspiring. I'm Charlotte Morris. Like Sarah said, I'm one of the members at large of the exec board for Wonka Europe. So I'm representing the Wonka Europe exec and EYFDM, the Young Family Doctors movement as well. Yeah, delighted to be co-hosting. Looking forward to Tara's talk. So I'll hand over to Sarah now. Sarah, as many of you know, works tirelessly advocating family medicine within Europe. So she's going to tell us a little bit about the Working Party for Policy Advocacy and then what we can expect from Tara's talk as well.
Thank you, Charlotte. It's my pleasure just to lead the Working Party on Policy Advocacy at Wonka Europe. As you know, we have been working in the last 2 years, and we have been trying to advocate in the European Parliament, European Commission, WHO, and everybody else who can be related with primary care. So now we are quite focused in the recognition of the specialty by the European Union, that unfortunately they don't think we are specialists, but we hope that they can be very well informed and they change the law. And so we have the opportunity to meet somebody from Tara Kiran team in the Lisbon conference in September in this last year. And so she shared about this initiative that is called OurCare that happens in Canada. And so we were very curious about what happened in Canada. And actually, we have several people from Canada who attended our workshop during the Lisbon conference about how to advocate primary care and how to make family medicine more visible for the politician and also stakeholders, so we can have more resources and our patients can have the right access to a family doctor. So it's my pleasure to introduce yourself to Tara Kiran. So she is a family doctor. She is also a researcher in health systems. She has published very interesting research in the last year. So please check her name in PubMed because I'm sure you're going to learn things that you haven't learned. She holds the Fidani Chair in Improvement and Innovation at the University of Toronto, Canada, where she also serves as Vice Chair, Quality and Innovation for the Department of Family and Community Medicine. I think if you say that, you can be impressed, but unfortunately, you can even be more impressed because Tara, she has a podcast which is called Primary Focus. I'm going to share the link in the chat so you can follow her and so you can learn about what happens in primary care across the world. And she started this initiative in Canada to collect the information of patients to advocate for primary care. And I think we are quite impressed because she made real changes in Canada's policy. And we are also very excited because yesterday, I guess everybody listened about the Canada Prime Minister. So he was not the only good speaker in the world. And we are very happy to introduce you to Tara. So Tara, the chair is yours. Please share your slides. And we are very excited to learn about your experience. Thank you so much for making the time to stay with us. It's a pleasure to have you here with us this afternoon.
Thank you so much for having me and for that warm welcome. I look forward to the dialogue that we're going to have together over the next hour. Yeah, it's, a challenging time in our world. And I think we all are here because we believe in the power of primary care. We also know, though, that in many of our countries, primary care is not what it should be. We have a vision for where it should be, but it's not there. And, I myself have been a family doctor for about 20 years and in research for about over 15 years. And during that time, I saw lots of attempts at primary care reform in Canada. And I noticed that when we had those reform attempts, usually there were specific people around the table, maybe family doctors, researchers, policymakers, people who lead healthcare organizations. But it was pretty clear to me that there was an important voice that was missing, and that was the voice of patients in the public. To me, the very people that the system should be designed around. We didn't hear their voice, and instead we had many different interest groups kind of putting forward their ideas. And although we were all there for patients in the public, I think it's easy sometimes to lose sight of that and sort of get into your own interests and silos. And then sometimes it would be hard to advance change because people wouldn't agree, or they would agree on doing something that ultimately actually wasn't in the best interest of patients and the public. So, that's why we started OurCare. OurCare is the largest ever national initiative in Canada to engage patients and the public about the future of primary care in Canada. Over 16 months, we heard from nearly 10,000 people in the country who collectively spent about 10,000 hours with us, telling us about their experiences of care, but also about what it is that they wanted to see in a better system. So today I'm going to tell you more about what we did in OurCare, what we heard from patients in the public, where we're at in Canada in comparison to what it is that people wanted to see, and then also kind of how we've been able to move forward in some policy areas and the work that still needs to be done. I do want to acknowledge right at the start, though, that this was a very collaborative process that involved a lot of people. In particular, I did this work in partnership with a wonderful organization called Mass LBP. LBP actually stands for Led by the People. It was founded by my colleague Peter McLeod, who really believes that ordinary people can solve complex problems. You just need to give them the right education and facilitation. And he's been doing this kinds of work around citizen assemblies for over a decade and a half in many different kinds of topic areas, including many topic areas in healthcare. And it was really with his partnership and vision that we conceived of OurCare and executed it. We also were lucky to get funding from Health Canada, as well as a couple of foundations from Staples Canada and the Max Bell Foundation. And importantly, this work was really guided by a lot of advisors. We had about 7 advisory committees. We started off with a couple of national committees, and then as you'll see, Canada is a country with many different provinces and territories, and we ended up doing a deep engagements in 5 of our provinces. And so really engaged kind of key stakeholders in those provinces, people who led important family medicine related organizations, people in government, people at universities, researchers, other leaders within the provinces. And they really guided us in making sure that what we were doing fit the context and where we were. So before I begin and tell you more about OurCare, I do feel like it's important you know a bit about Canada and the Canadian context. Of course, Canada is next to the United States, and no, we are not the 52nd state, as much as some people like to joke about that. We are, of course, a sovereign nation. We have a large land mass over which 39 million people are distributed. And importantly, we're built on this legacy of colonialism, where colonizers from Europe, the French and the English predominantly, came and settled here, displacing and killing many of our First Nations. Because of that legacy, though, we do also have a largely English-speaking country, but also a pockets that are French-speaking, and French and English are 2 official languages. We are also a country built on immigration with, they say more than 450 ethnic and cultural origins really being represented, and a large number of immigrants. Canada's healthcare system does provide, so we do have a public health insurance. And that health insurance is really administered in every province and territory. It's a tax-based health insurance system, and it covers medically necessary physician and hospital services without any co-payments, including visits to family doctors. However, there's many other things that are more variable in the way that they are covered. So for example, things like prescription drugs, home care, long-term care may only be covered for a portion of the population, or not hardly covered at all. I also think it's important context that, Canada, although we have a public insurance system, and we think of ourselves as having a publicly funded healthcare system, actually the proportion that we spend on public versus private financing in healthcare is actually less than many of our peer countries. And importantly, actually, Canada does have we all are facing health human resource shortages. And I will say, I think it's actually worse in Canada. When we look across, this is actually comparing Canada to 9 OECD countries, but when we compare actually to a more fulsome set, Canada still is really near the bottom when it comes to the number of doctors per capita. And so that's a particular challenge that we need to think about. So I mentioned that our healthcare system is provincially and territorially delivered. So what that means is, depending on which province or territory you live, you might have a different health card. And actually, the way primary care is set up, how doctors are paid, their accountabilities, whether there's interprofessional teams, actually all really varies by province and territory. I live in Ontario, which is Canada's largest province from a population perspective. And so we'll talk a little bit more about Ontario today as we think about the policy translation of the work. And then I did mention, that we are a country with a large immigration base, but built on a legacy of colonialism. And I think it's always important for us to acknowledge that even though we have this universal health insurance system, there's still wide disparities in health and access to care, and particularly our First Nation, Inuit, and Métis struggle with poor health outcomes and poor access to health care. And a lot of that is that legacy of colonialism that we are trying to reconcile with. So with that context, I'm going to step back now and tell you a little bit more about OurCare and the work we did. So OurCare was conducted in 2022-23 in 3 phases. And I'm going to tell you in turn about the different phases. So the first was a national survey. In this national survey, we heard from about 9,000 people across the country about their experiences with care. Did they have a family doctor or not? Were they able to get in to see them? But also what they wanted to see in a better system and kind of some of the trade-offs that they were willing to make, or what was more important to them, if they were given options for a future system. But people have done surveys before, so I don't feel like this is by any means the unique part of our work. In fact, it was really just the beginning part and a touchstone to understand kind of how things looked at a broad level across the country. The unique part of our work really was dialogues with patients and the public. And I think the signature part was these 5 provincial priority panels. So in each of 5 provinces, we actually gathered together randomly selected individuals, about 30 to 35 of them. These were strangers who had never actually met each other. This is a photo actually of the group that we gathered in Ontario. And, we brought them together, randomly selecting them based actually on their demographics. So in Ontario, we asked for volunteers through our survey and through our partners. And we had about 1,250 people that said, yes, I want to volunteer 30 or 40 hours with you to talk about primary care and how we can make it better, which is actually amazing engagement if you can think about it. And what we did is we randomly selected from that pool of 1,250 based on these 8 demographic characteristics to ensure that we were getting people that roughly represented the demographics of the province with some extra representation for underserved groups. And so you can see here kind of, this is our province of Ontario with, most people living in our urban centers, but this is a depiction of where the participants came from. And we like to think about it like we brought the province into a room together for 40 hours. And so what did they do together in those 40 hours? We had, in Ontario's case, 3 virtual Saturdays where they gathered for 3 to 4 hours and did a lot of learning about primary care. And then they had an in-person session for about 4 days. And through all of this time, there was learning about primary care, but as the time went on, more and more of that time was actually spent in deliberation, in small groups, thinking through things like, what are our shared values? What are the issues that are most important that we need to address based on everything we're hearing and learning? What are the priorities for the things that we really want to have happen? And then finally, what are the recommendations? I will say, I think these are things that you and I grapple with all the time. And I know that they're really challenging. And I will say that, our participants found it challenging. And we actually, warned them that during this process, they're going to hit something called the diamond of despair, where they hear all about the problems and the complexities. And then it's really hard to figure out how do you move forward, but that through the dialogue and the engagement, they will. And sure enough, in every session, we did have success in people coming together despite their diversity to really think through what their shared values were, the issues, and then the recommendations. And each time they did this, they actually wrote their own report, which we published on our website. So I'll get in a moment to what we heard from them, but I will say that was the group that we convened in Ontario. This was the group in Quebec. We then did it in British Columbia, in Nova Scotia, and finally in Manitoba. Now, we knew that even though we really tried to make these panels representative and inclusive, meeting people's needs, we knew that the process by, in large part by the design itself was probably going to make it difficult for some people to participate, and that we were missing some important voices. And that's why we designed our third phase, the community roundtables. We did these in partnership with community organizations that had established relationships with underserved communities that we know historically have had challenges with access to primary care and worse health outcomes. And so that included our Indigenous communities, members of the Black community, newcomer communities, as well as people with disability and the LGBTQ plus community. And so over one day, we had gatherings where 24 people gathered from these, from a specific community, hosted by a community organization, and, learned about primary care, learned about the recommendations from the priority panel and their jurisdiction, but then thought about, what are their specific needs? What were the things that were working well for them, and what needed to change, and put forward some action ideas. So this is just a photo of one of the roundtables. This one was in Durham, Ontario, so about an hour from where I live. But it's a community with a lot of new immigrants. This community roundtable focused on the needs of the African, Caribbean, and Black communities. And actually, I think importantly, there were a lot of intersectional identities here. So, many of the participants were new immigrants to Canada. Many came from the African continent, and actually many were French-speaking and found it challenging to find services in French in the place where they were living. So lots of interesting kind of issues that were raised by them specifically. So all in told, we published 17 reports, one after each of our different engagements. And then, in February of 2024, about 2 years ago, we published our final report that really pulled together everything that we heard from our consultations across the country. And so I want to tell you more about what it is that we heard and the consensus that we heard. But before I do that, I feel like it would be great for you to actually meet some of the people that we heard from, so you get a sense of why it is that they participated and the kinds of things that they learned from the process. And I feel like that's going to really bring it to life for you. So I'm just going to share this short video of our members of people who participated in the priority panels across the country.
I volunteered to be a part of the OurCare panel because of my own health issues. I struggled between having a doctor, losing a doctor, and then having a doctor and losing a doctor, and being resorted to walk-in clinic, which has not been able to help me in my own healthcare needs. And I wanted to be able to provide our voice to the people who make policies in order to try and make it a better experience for other people going forward.
And knowing that my generation is going to be inheriting this very important system, I feel like it's my duty as a citizen to do my best to build a system and improve it so that it can be sustainable for the long term.
Ce que je trouvais qu'on a en commun, c'est chacune de ces personnes qui sont ici présentes, de ces collègues, ils sont ici pour le même but, de se faire entendre et d'apporter d'amélioration.
I'm not as alone as I maybe thought I was. Everybody, even though you have different backgrounds or different histories or different needs, all really at the end of the day wants the same thing, which is a healthcare system that works for everybody.
Whoa, okay, I'm not the only one, and realize that a lot of people have the same goals in mind in regards to healthcare and how they want to improve healthcare.
I felt like I was a pretty good navigator of our healthcare system and found out there's so much I don't know. And so if I don't know as someone who thinks I know quite a bit and has used it a lot, how much do other people not know?
To bring 36 people together with varied backgrounds from various parts of the province to get together, and literally in less than 2 full days of working, we're developing strong, actionable recommendations.
Because I know personally, I'll take, whatever I've learned over the last 4 days back to my own, town and area, and try and continue the work that I've come to realize as being important here in the group.
I have learned way more about how the healthcare system in this province works than I ever thought I could learn this quickly. I've also learned, though, that the answers to the current crisis are probably in the room with us. We just need to get the right people to listen.
So as you can see, that process was really a pretty impactful one for the people who participated. And there were many different reasons why they participated, but a lot of them were just altruistic. They wanted to improve the things for themselves, their communities, the future. And they really valued the learning that they received during the process as well. And so as you also heard, there was like a real diversity in who we heard from, but there was so much agreement in what it is that they wanted to see in a better system. And so what we did was we summarized what we heard from them in this final report and introduced in particular something we called the OurCare standard. And so these are 6 statements that describe, in our opinion, what every person in Canada should expect from the primary care system. And they're really a distillation of everything that we heard from the public. The first was that, everybody should have a relationship, of course, with the primary care clinician, but they wanted to see that, strengthened by clinicians working in interprofessional teams, recognizing that, clinicians on their own wouldn't be able to actually meet all the needs, given we have a shortage of family doctors. And they wanted all that to be publicly covered. They wanted care that was timely and ongoing, including care that was after hours, where virtual was integrated with in-person. They really wanted to take a wellness-oriented approach and not a sickness one, and wanted primary care to be connected to community and social service to support overall well-being. And then the 4th standard really speaks to people's frustrations at not having access to their own health record. In Canada, that's not something that's legislated, and in fact, many people struggle to get that. And so the 4th standard is about how we need to give people access to their health records online. The 5th standard speaks to instances of racism and discrimination we continue to hear about, and how people deserve culturally safe care that meets their needs. Regardless, if they have a disability or using a different language, and that also, that the workforce needs to represent the communities it serves for us to be able to deliver that culturally safe care. And then the last standard talks about accountability for primary care to the community. And that encompasses concepts like transparency, so reporting transparently on how our system is doing, how much we're spending on it, and what we're getting on that return, but also involving patients in design of our health services and how they work. And finally, empowering and educating the public to be able to navigate the system, something you heard about in that video. So it's a grand vision. And, I think it's one that when I've presented it in Canada and elsewhere, I think really resonates as something that, we can see that it has face validity on what not just patients want, but I think actually when clinicians see it, they agree that this is what's needed in the system. And so I want to tell you a little bit about kind of where are we now in relation to this standard. I mean, we know that this is what we need to be shooting for. And over the last few years, the last couple of years since the standard was released, we've done a lot of work with governments to get them to adopt the standard, which we'll talk about. But one of the things that we are doing is trying to measure where care is now in relation to that standard. And so we actually in 2025 did a follow-up OurCare survey. This one was different, and it really did measure against the standard. We asked questions related to each standard element, and we put the results out in a report just in December, so last month. And importantly, when we started the work, our first survey estimated that there were 6.5 million people in Canada that didn't have access to primary care. By the time of this survey in 2025, we estimate that number is reduced to 5.8 million. So great to see things going in the right direction, but still very striking that there are so many people in Canada, a system where we think about having universal health insurance, that actually just don't have access to a family doctor, nurse practitioner, or other primary care setting. We asked a lot of other questions, and I'm not going to be able to go through all of it, and you can take a look at our report that's on our website, but I do wanted to highlight a few things. So as I mentioned, the percentage of people with a family doctor or nurse practitioner or their team increased over between 2022 and 2025. But what we continue to see, though, are disparities. This graph is highlighting disparities in income. where we see that, if you make less than 20,000, 70% of people in those groups have access to a family doctor or other primary care source, compared to 85% of people who make 200,000 or more. So really striking disparity and really a gradient based on income. And even those who do have primary care are struggling to have access. So, only 45% said that they always or usually could get care from their clinic if their doctor was away. Only 31% said that their practice had any kind of availability for urgent issues outside 9 to 5, Monday to Friday. And only 37% said they could get a same or next day appointment for an urgent issue. We also included some new questions just to, make it clear that for people, primary care wasn't just about access, it was about other concepts as well. And so this is an example of one of those questions where we asked people about, whether they agreed that the staff at their clinic or where they had to get care understood and respected their cultural background. And we see that if they did have a primary care clinician, about 70% said that that was the case. Should we be doing better than that? I think so, especially given that, about 25% of people are immigrants. And, but of course, if people didn't have a primary care clinician, it was even less likely that they had a place that was understood and respected their cultural background. We also had, importantly, questions about access to health records. And we can see here that a quarter of people who responded didn't know if their health records were available online. And, it was only some health records that were for even the people who did know. So 56% said that their lab tests would be available online. But only, 6 or 7% said that notes from their family doctor or nurse practitioner would actually be online. And then what we saw was just real dissatisfaction with the system, with only about 28% saying they were satisfied or very satisfied with how the primary care system was working. So that's where we are now. How do we get to a place that's better, where we actually achieve what the public put out as their vision for primary care? As I mentioned, we've been working a lot with different people of influence, people in government, but also leaders in the medical community, advocating for primary care, but also how can we achieve this OurCare standard? And in June of last year, actually, one of the unthinkable kind of things almost happened, where actually the government of Ontario, the province where I lived, passed a first of its kind legislation in Canada, a Primary Care Act that actually centered primary care as the foundation of the healthcare system, and then asserted that, there were 6 objectives that primary care had. And you can see those objectives laid out on the right. And what you'll notice is that the 6 objectives match concept for concept the OurCare standard. The wording, though, is different. So, for example, the standard 2 is standard element 2 is everyone receives ongoing care from their primary care team and can access them in a timely way. The legislation uses the word convenient, which the government of the day likes to use in many different contexts, that they want to make everything more convenient for our population. But the concept is that every person should have access to timely primary care. We use the term culturally safe care. They use the term inclusive. Every person should have the opportunity to receive primary care that is free from barriers and free from discrimination. And I should mention that this Primary Care Act was actually passed by a majority Conservative government in Ontario's Parliament in June, and it was passed unanimously, I believe. Now, how did we manage to get to that policy change? I know that's of interest to this group. And when I've reflected on it, I think there are a few things that are of note. I do think it was really powerful that our process amplified and put forward the patient and public voice. We weren't coming to them as an interest group, as the Medical Association or Association of Family Doctors. We were coming to them as researchers who had really worked with patients in a very deep way and understood what it is that they want to see. And I think that did resonate with the civil servants and the politicians and political offices that we met with. And it was a way, I think, to get agreement. It's hard for anyone, including professional organizations or doctors groups, to argue when patients in the public are saying this is what we want to see. We also did strike a broad coalition. So it wasn't that we did this work in isolation, but as you saw, we had that huge number of advisors, more than 60 organizations that were working with us. And in the context of Canada, we also did it in many different provinces and territories. So we did something that was relevant in a specific province, but also because we did it in so many provinces and territories, it actually was relevant nationally, and the same themes kept recurring. We had a rigorous process. Some of it was more research-based, like the survey. Others was more related to kind of public engagement processes and, didn't go through a research ethics board per se and not traditional research, but was rigorous nonetheless. At the same time, though, when we published plain language reports and put something like this OurCare standard forward, which really actually simplified the findings. I mean, we have 17 reports out there, but nobody has time to read all those reports. People can digest, though, the 6 statements of the OurCare standard. And so I think that's another reason why it was able to get traction. We really had very strong and consistent media engagement all throughout our process, starting with actually even recruiting people to respond to the survey when we launched it, all the way up until the final report. And then again, continuing now with our next survey that we just released in December, and we're going to do a follow-up report on results in February, and I expect that to get lots of coverage too. I mentioned the direct engagement with policymakers. I think the last thing to say is that we did do this work very fast, faster than research is traditionally done. And that's partly because I worked with a non-research organization. And it was only because it was done fast that we were able to take advantage of a window of opportunity. There were a couple of different windows of opportunity. One was that our government nationally, so our federal government, was interested in the area of primary care and had been working with every province and territory to negotiate a new agreement for increased funding to healthcare with 4 priority areas, one of which was family health care. And they actually, part of the reason they funded OurCare, I think, is because they can't tell province and territories what to do, but they felt that through funding OurCare, they're amplifying patient and public voices that put pressure on provinces to actually use the money in a wise way for primary care. The other window of opportunity was very specific in Ontario, and I think in some ways this is a window that we could never have predicted, but also that I think we helped create through our advocacy work. We, along with many others, had been advocating for primary care to have more attention and funding for a long time. And, that got really accelerated during OurCare. That also coincided with the pandemic winding down and there being some challenges and lots of patients being upset and CEOs of hospitals even recognizing that we didn't have proper primary care. And the province eventually acted on that by actually appointing Dr. Jane Philpott, who is a family doctor, but also was actually the federal minister of health in a majority Liberal government previously, to be almost like the primary care czar. She was going to lead something called the Primary Care Action Table. And they appointed her basically just over a year ago. So she started her work in December of 2024. And Jane had actually just written a book called Health for All, which she had published. And in that book, actually, she had described how she felt like federally we needed a Primary Care Act. Now, Jane wasn't able to get that Primary Care Act federally, but she was instrumental in the Primary Care Act coming to be in Ontario and has always been a big supporter of OurCare. And I think that's why the OurCare standard is reflected in that Primary Care Act. So the government has appointed Jane Philpott, and they've also committed $2.1 billion in money to actually improve primary care access with the goal of attaching everybody in Ontario to primary care by 2029. But we do have a long way to go in terms of, at the time they did this, it was estimated 2.5 million people in Ontario didn't have access to primary care. But at the same time, we also had infrastructure that we can build on, particularly interprofessional primary care teams. And it's through these teams, really, that I think Jane Philpott and her team are hoping that we're able to transition Ontario to a province where there is primary care for all. Back in 2005, Ontario introduced interprofessional primary care teams, but really only a quarter of the province or a quarter of residents are currently in a team. So this is a team where family doctors are paid through capitation, which is like a set fee per patient per year, and where they have funding from the government to hire professionals like nurses, nurse practitioners, social workers, dietitians, pharmacists. It may be different for different teams, but these other health professionals to support care delivery. And the idea is, can we actually leverage and expand these teams so that they can start to care for more people? I will say I myself work in such a team. So this is a picture of my own team in Toronto. I will say that it is a wonderful way to practice from a clinician joy and work perspective. I think it's wonderful to have teams to be able to collaborate with and to particularly to share the care for complex patients. We've done a lot of research, which I'm not going to summarize today because it would just take too long, but I'm happy to answer questions about it, just to say that we've done a lot of research to understand the effectiveness of these teams in relation to models that don't have a team. And we'll say that the evidence is a bit mixed. We do see some areas of higher quality care, and in other areas, we actually don't see a lot of difference. But I think the question that we haven't answered in Ontario, and which we're really going to need to do better with in order to translate this vision of primary care for all, is, can we actually use other health professionals in this team model to have family doctors care for more patients? We know we have a family doctor shortage relative to their population needs. Right now, let's say the average roster might be 1,200 people. Can we increase that to 1,600 by putting a nurse, for example, into the team? That hasn't been shown yet actually in teams. And it's something that there's actually not a lot of evidence to guide us on. And so it is an area that we're actively working on provincially. And I think the researchers and people on the ground are thinking through. It's now come up to the 1-year anniversary of Jane Philpott and her team doing their work. And they've managed to have quite good progress through, releasing money for new teams, and even in the short time. And you can see kind of this dotted line is their trajectory of how many people they want to attach by 2029. And they can say confidently that they've attached, in the last year, an additional 275,000 people in Ontario, and that they've dropped the number of people who don't have a family doctor significantly. So they say they're on track, and we are all really behind them and trying to support them to achieve this vision. I do personally have hope that we are going to be able to do this, and think it's a unique moment for primary care in Canada. I feel like it's also really important for us to learn from each other in the country and around the world, so that we can, on the ground and through policy, build out the primary care system we want and learn from what's working. So I've started this podcast, as Sarah mentioned. It's called Primary Focus. And in it, I tell stories about health systems and also clinics where they're doing fantastic work in primary care that we should be learning from and replicating in different ways. I do a great series in the Netherlands where I actually had an opportunity to visit and I do sort of a 4-part audio documentary there. We recently were in Costa Rica, a very different healthcare system. And this episode that I'm highlighting here is actually this fantastic team in Calgary, Alberta, Canada, that actually has really figured out how to use teams to increase the capacity of doctors to see more patients. So they've really figured out how to do this very efficiently and take a continuous quality improvement approach using data and patient feedback to improve their care. Really impressive work. So with that, I'm going to end, and I look forward to taking some of your questions. Thanks so much for having me today.
Thanks, Tara.
Thank you, Tara. So it's our pleasure just to listen to your story. Somebody sharing in the chat that this was very inspiring. I think we agree. And so we have just like 15 minutes for questions. So please don't be shy. If you can write your questions in the chat, I'm sure Tara can answer them. She also shared her email in case you haven't shared it or you haven't taken note. We are happy to share with you. I'm going to put again the links in the chat. So we have the OurCare initiative, we have her podcast, and I'm also going to share the Working Party Policy Advocacy WhatsApp group that we share some news about policies and EU events that are happening. So if you want to share a little bit, it's only for reading the events. It's not just for talking, so you can silence us just in case. I'm going to share the 3 links. So you have everything. Then I'm going to pass the mic to Charlotte if she wants just to start with some questions. And if not, I also have some questions to do.
Great. Thanks, Tara. I had a question myself, Tara, to kind of start things off. So I thought the whole talk was inspiring, but what particularly inspired me was how you managed to bring patients right into the heart of what you were doing. And it was particularly good to see the diversity of the patients that you had within your panels as well. So I wondered if there were challenges in recruiting that diverse group of people, more so than recruiting a less diverse group, and how you overcame those challenges as well. I think that would be really useful for us in a European context.
Yeah, I think it was challenging and is challenging to ensure that you're really hearing from a broad swath of the society. I think when we, initially we do a broad call and, have the people who volunteered. And as I said, in Ontario, a lot of them came from the survey that we did and just raising their hand. We also advertised through our community partners. And then when you look at who has volunteered, you can see where there are or aren't gaps. In Ontario, we had such a large group that I think there were less gaps, but in some of those provinces where we went to later, we could clearly see, okay, we didn't have representation in the north, or maybe we didn't have as many immigrant voices, or we weren't as ethnically diverse as we needed to be. And so that required us to really reach out to different partner organizations. So MassLBP in particular, I think, has connections with different organizations that do different kinds of patient, public, citizen engagement work. And I think that those connections were really important. I'm not going to name the types of organizations because I think they're going to be different, but I can imagine in any society, there are people who organize on the ground, community organizations who these could be, providing services in a very local setting, or they could be connecting people more broadly in a region. But it was those kinds of connections that enabled us to get it for the priority panels. And then I will say for the community roundtables, that was a different kind of challenge in some ways, because we really wanted to work we recognized that in order to really work with marginalized communities, we needed to do that through a partnership with a community organization that had established trust and relationships with these communities and could bring them together. And a lot of those organizations, unfortunately, are just like underfunded and basically don't have the resources to do their work on a day-to-day basis. And so partnering with us, even though they wanted to do that, a lot of the ones that we approached actually declined because they just couldn't do it from a timeline perspective or a resource perspective. And so it was persistence on our part. In some of the provinces, we actually, had to go to many different partners before finding one that was interested in working with us. We did at the outset have an idea of I knew that I wanted to have the community roundtables have a really good representation of Indigenous voices, Black voices, and newcomer voices. And so those three groups were really important to me at the outset. And so we did focus in on that. And we also got advisory group advice on what was important in that context given the advisory group. And then we also used our advisory group members to help connect us to different organizations as well. And then myself, MassLBP, we use lots of our contacts to try and find organizations that we could work with. So anyway, that's a long answer, but some of the work we did behind the scenes.
No, great. And I think how I would reflect on that is it applies to so many different roles for us as primary care clinicians, as researchers, as clinicians, and in terms of the policy advocacy work being done by the Working Party as well. So I think really helpful in a number of contexts. And a next question has come in about the awareness of the continuity of care benefits. So how much awareness has there been of the benefits from the continuity provided by OurCare? And how has it been built into proposals is the next question we've got.
Yeah, so I mean, I think all of us in primary care, I think about the 4 or 5 C's, depending on which ones you count, and think about continuity, and know continuity is a real essential component to, and there's different kinds of continuity, of course, but relational and informational are the two that I think about the most. I would say there, when we as we talked about, when we did the priority panels and the roundtables, a big portion of the time is spent educating patients and the public, and we teach them about the 4 C's of primary care and some of the evidence to the degree that we can. And I also will say that it is something that people also intuitively want. They want to have a relationship with with someone, and they also want to have access to their records. Actually, we didn't teach, I think, informational continuity. That one came out organically time and time again. And so I think you can see continuity, I think, in those two standard elements. Standard element 2, where it talks about timely and ongoing care. We use the word ongoing because we think it's a more lay-friendly term. And then in the access to health records, which ultimately is about the continuity of information, which is a big challenge in Canada. I see there's a lot of questions, actually.
Yeah, there's a lot of questions. I think with continuity, I suppose one comment maybe we'd agree with is it's nice for us as the clinicians as well as it being nice for the patients. It's nice to see.
Patients definitely want that, and that was clear in OurCare.
Yeah. So I think the next question I can see is the approach of having multidisciplinary teams to support and increase the capacity of primary care is innovative. Does OurCare advise on education and upskilling sustainably to build capacity amongst the teams? And there's another question about the division of tasks. So maybe you might want to comment on both of those aspects, if that's okay, Tara.
I think interprofessional teams and using them effectively to enhance capacity is a growing area and a nascent area in primary care. And so I think it's fair to say that every jurisdiction in Canada is figuring it out and has different approaches. I think as researchers, not through OurCare, but through other research we've actually done some evaluations of the teams to date that we've provided to government. Some of it has been commissioned and some not commissioned, but it really showed, for example, a study that we haven't published yet, that actually the teams that exist have not increased the capacity of clinicians to see more patients. And we think one of the main reasons it hasn't done that is because the objective wasn't clearly set for it to do it. And so the teams weren't designed around that. So the teams, what ends up happening is you end up delivering more care to the same patients, which patients like, and it's nice for doctors and the team members, but doesn't ultimately get you more capacity. And the government now recognizes, I think leaders now recognize that's a challenge. And I think there's a lot of activity on the ground to try and figure out, I don't think we know, what is the right nursing role? What are the right team members to actually enhance capacity? Is it a nurse? Is it a social worker? Is it a pharmacist? How many more can you get with this, and what kind of composition, what role description? So this is all still happening, and there's definitely an educational piece, both for existing teams and for our next generation, that needs to be addressed. And I'd say it's not something that OurCare is necessarily moving forward, but I'd say many people in the system are. Maybe I'll just see, I've been skimming some of the questions, Charlotte, and I see there's some related doctor assistant too.
Yeah, I think that would be the next one, about the satisfaction of Canadian family physicians. And there was another similar related one, and what's being done
about the increasing the number of doctors in Canada. So I think governments have now recognized that we don't have enough doctors. And so there's lots of new actually medical schools opening up across the country. And there are also within current medical schools, more spots opening up and more than residency positions specific for family medicine. One innovation, something that's new, is there are a couple of new medical schools that actually are focused on training family doctors specifically. So you come out, I think, still with a general medical degree, but the expectation if you're going to this school is that you're going to be going into a family medicine residency. And in one of the schools, it's actually you're committing to going into a rural family practice for at least 5 years in that area. So that's in Nova Scotia. So some interesting work being done to try and really incentivize people in family medicine. The challenge, though, is that family medicine is not it hasn't been an attractive profession for medical school graduates and for a residency graduates. So we see, declines in the number of medical school graduates choosing family medicine residency as their first choice. We've also seen over time that even people who graduate in family medicine residency, fewer of them are choosing to practice in full service family medicine, and more the people who are actually been practicing family medicine, who are family doctors, are leaving the comprehensive practice and doing other things. And so what are those other things? It's like working as a hospitalist in a so that means taking care of sick patients admitted to hospital, working in the emergency department, doing addictions medicine, maybe palliative care. I will say these are all important aspects of the healthcare system. And when you have a doctor shortage overall, generally trained physicians have a lot of opportunities to do different kinds of work. But the challenge is that, we have now some hospitals where people have multiple most responsible clinicians looking after them, whereas in the community, we have many people who have no family doctor. So we do need to reconcile our incentives. One of the things that's making family medicine less attractive, really, there's lots of things, but one is like it's a small business. The pay isn't necessarily kept up with other specialties. When you have a small business, cost of living increases. That means the cost of the business is increasing. New graduates don't like to commit to having a small business where they may not be able to take a vacation or parental leave. So there's like those kinds of barriers. And then there's also barriers like administrative work. We have dysfunctional information systems and a lot of burden of paperwork that comes back to family doctors.
Yeah.
So I think a very high-level overview.
I think, Sarah, I'd say that sounds very much like family medicine in the UK. How about in Spain as well?
I think we also have our own challenges. I think we share lots of challenges worldwide at this moment. So I think what I see in the chat is like everybody sharing more or less the same concerns: continuity of care, the satisfaction of family doctors, quality of the work, also the education of the patients, the alliance with the patients. I think that we have lots of challenges that we share. And so we have 2 minutes to 6 p.m. And so 6 p.m. in Madrid, part of Western Europe time. So thank you so much, everyone, for joining us. I think it has been quite inspiring. Also, it has been nice just to recognize that there is always something that we can do. And I think Tara's initiative with all her team is a way to show that you also can add something else. And sometimes this something else can bring some changes, which is the case from Tara. I guess you still have challenges just to make the Ontario Act to get to the whole Canada, not only to one province, but the whole country. But I think all of us are just working on it. So I would like first to say thank you, Tara, for sharing this hour with the Wonky Europe community. Also, we would like to recognize your team, all the patients who participate in the initiative, all the stakeholders to support you. I think it's quite impressive that we can work together to make this happen. And I think that all of us in Europe that are small countries here and there, we can just be inspired by your example that we always can work together to improve primary care and family medicine. So thank you, everybody, to spend this evening with us. Thank you, Tara. We are expecting you in Paris. We would love to see you. And I'm sure that at least 55 people are going to know your face. So if you are coming, probably we're going to tell you bonjour. So I hope you are ready. Thank you also, Charlotte, to spend this evening with us. So thank you, everyone, for sharing this afternoon. And we would like just to say our special words for Burak. He always makes everything happen so easily. And he makes us being comfortable and learn a lot about primary care in the last hour. So thank you, everybody. Have a wonderful evening and see you in the next Wonky Euro Talk. Bye.
Bye.
Thank you. Thank you for having me. Wonderful to have this collaboration.
Thank you.